Welcome everybody to today's webinar. This is the FAAN Artificial Intelligence and Technology Collaboratory for Healthy Aging webinar, part of our collaboratory funded by the National Institute on Aging. Today, we're very happy to have with us Dr. Brody from New York University. Dr. Brody is the Mathy Mezey Professor of Geriatric Nursing, Professor of Medicine, and Associate Director of the Harvard Institute for Geriatric Nursing at NYU. He founded Aliviado Health, which seeks to help healthcare systems and settings improve quality of care for persons living with dementia and their caregivers. His work focuses on developing the science of equity-focused, technology-driven pragmatic trials in geriatrics and palliative care. He practices on the Langone Geriatrics and Palliative Care Services, and he is the pilot core lead and steering committee member of the NIA IMPACT Collaboratory. We're very happy to have Dr. Brody with us here today. And before I hand it over to him, just reminding our audience that you can post any questions you have during the talk using the Q&A feature on your Zoom. And at the end of his talk, we'll have a discussion and we'll be able to address any questions you have. So with that, Dr. Brody, thank you again for joining us today.
Thank you so much, Dr. Damiris and the Penn AI Tech Center for having me here today. I look forward to having a really thoughtful discussion with folks. And as people move along, if they have questions, feel free to throw them into the chat or otherwise, and I'll be happy to answer. Otherwise, as we move through towards the end, I'm going to start off today with a disclaimer, because mostly in academic research, right, we move really, really slowly. And so I think one of the challenges and thoughts is, how do we turn that around while still maintaining research and rigor? And how are we really responsive to our end users and the people that we're trying to help, even if we have wonderful ideas? So really today, I'm going to focus a lot around how are we moving forward in a quick fashion, a thoughtful fashion, and a rigorous fashion, but one that is almost more akin to where a startup might be, maybe not quite as fast, because startups tend to be singular-minded on a single problem, whereas I think in academics, we get pulled into multiple different places, but to really think thoughtfully and quickly while also using keeping our end users as the center of all of this. So let me share my screen and then we can move along here. So just briefly, I have no disclosures, and this work has been funded gratefully by NIA as well as some other foundation funders, and the content is solely the responsibility of the authors, meaning me and some of my co-investigators and team, not represent the official view of NIH. So before I get going, I did just want to share a little bit about HIGN at NYU Myers. We have been an institute at NYU for almost since 1996. So we're going on 28 years now, if my math is correct, as we go into the new year. And our goal is to really help implement interdisciplinary practices and help the workforce across disciplines to implement evidence-based, effective, age-sensitive, and equitable healthcare for older adults. So we have policy, practice, implementation, and research arms, and that's where I am nested as the associate director and have a lot of tools both available on our website as well as some other things that we've been developing that are there to help improve age-sensitive and equitable healthcare. And so I thought it'd be important to start with a mission moment, because we often get into graphs and charts and what are we doing and all of this, but we kind of forget where does this all come from, right? And so where this came from for me, I was a house calls nurse practitioner in the Bay Area, in San Francisco Bay Area, which is also one steeped in technology. And so grew up with both, so to speak, with both technology and seeing older adults in their homes providing old-timey, old-fashioned house calls. And I kept coming across this challenge again and again that care partners were stressed and strained and didn't feel they have the resources that they needed. And healthcare teams didn't really understand how to care for older adults living in the community, particularly those from underserved communities and those who have dementia, and how to address those. And so one example of this is I had a patient who lived in a assisted living facility in a memory unit. And I get a call from the hospice nurse one day that says, I think the patient is dying. She stopped talking. She is not really responsive anymore. And I think she's starting to hit her end. And so, in a normal primary care practice, if you got that call, the primary care provider would say, okay, and that would be that. In our practice, I went out and did a visit, found that the patient had a golf ball size pressure injury. Back then it was called a pressure ulcer or a decubitus. So they had a huge pressure injury on their sacrum, and it was causing pain. And as soon as we treated her pain and offloaded her pressure from where that injury was on her sacrum, on her buttock, she was back to her usual self, talking and being expressive. She had some fairly advanced memory problems, but it was a true mission moment that if we provide thoughtful and evidence-based care and the right supports to clinicians who really don't know how to work with older adults and persons living with dementia specifically, that we can really improve care and quality of life for people and really prevent some bad outcomes. So in this case, if we hadn't treated her and she had continued to be kind of lack of talking and not really engaging, she wouldn't have been eating and drinking, and she probably would have passed away sooner. And she still had another full 6 months of life before she ended up passed away. Those were moments that she could spend with her family, that she could engage in meaningful activities. So I think it's really important that we think, where does technology fit, as well as other components in helping to improve care? And so, if we think about the challenges of caregiving, they're immense. There's right now over 16 million care partners, which is the preferred term that I use in the United States, providing more than 17 billion hours of unpaid care. And caregiving, serving as a care partner, can have incredibly positive aspects of care. So I don't want to all talk about doom and gloom. There is intimacy that occurs by providing this care, and positive aspects, particularly in our minoritized communities. We've shown that African American, Black, and Hispanic Latino individuals tend to have more positivity surrounding their caregiving for their care recipient, for the person living with dementia, and that has a protective effect and creates more resilience in the case where there are many additional challenges, sometimes on underserved communities. So it can affect, on the negative side, people's mental and physical health, as well as finances. And so we really do need to think about how do we help caregivers and provide them the support they need. And I've become more and more sure over the years that we need to attack this challenge from multiple angles, from both a healthcare system angle, as well as from a on-the-ground caregivers through social supports and other means that do not involve the healthcare community. Healthcare community is not very quick to change things, except when you have big events like COVID occur. And so, there are some challenges around disparities, around the resources that people have, their education, the healthcare services they can attain, their support networks, all of which affect how supported people feel and the personal mental and physical health of caregivers. And these challenges start with poor early diagnosis of cognitive impairment and dementia. And so I think when we come to it, there are a lot of challenges, which means that there's a lot of opportunities to address these challenges. So if we think about some of the general health equity challenges in African American and Hispanic communities, there are higher prevalence rates of dementia, yet they are presenting later for diagnosis. So people are more likely to be diagnosed in these communities in the moderate to severe stages. And there are a number of different reasons for this. When they are diagnosed, they have higher rates of behavioral symptoms, also called neuropsychiatric symptoms like agitation, aggression, and yet at the same time in these communities, there's lower rates of institutionalization. So these individuals are being cared for at home with fewer supports and greater family care partner involvement. And additionally, we're seeing lower rates of advanced care planning, serious illness conversations, and hospice utilization that are occurring in this population. So we're not helping people to think through impact of decisions and having those conversations about what's important to them early on, because we're also not having things diagnosed early on. And this relates to a number of different reasons and mechanisms. And if we also look at our Asian American community, they are just completely understudied in relationship to this population. And so there's a lot of unknowns, and none of these populations are monoliths. Asian Americans come from, I think it's about 30 different countries roughly, and you have everyone lumped in here, from people from India to China to Japan, to Bangladesh. It's very wide ranging, Sumatra, etc. So there is understudy and lack of understanding of the cultural elements that we need to address when we're thinking about these populations. So as we think about this, there are a lot of different places to intervene, and I'm going to focus on a few today. Most of the machine learning tools that we have seen to detect cognitive impairment early in the electronic health record have really had poor discrimination in minoritized populations. They're not tuned effectively for these populations. The minoritized patients are more likely to be called agitated or angry in progress notes and given antipsychotics. In disadvantaged populations, there are fewer resources with which to provide non-pharmacologic interventions. And our communication protocols are largely delivered and developed with white Eurocentric populations as the evidence base that don't take into account historical mistrust, systemic racism, as well as just different cultural patterns around expectations for care and what is needed in different communities. So there are some challenges which also lead to intervention opportunities. And so today I'm going to focus on three things that we're currently working on. One is early recognition of mild cognitive impairment and Alzheimer's disease and related dementias, and slowing of cognitive decline using technology and supports. And I'm very want to be very clear here. Technology can play a key component, but it is a component. And I think for many of the things that we do, it also requires different types of support. And so, technologies are tools, whereas oftentimes there are many other supports needed. I'm also going to talk a little bit about, and that project is just starting, so it's fairly early, but I'll share a little bit about where we're going and how we're thinking about equitable design in that framework. And then I'm going to talk a little bit about using mHealth technology to support both clinical teams and how that's spun off into supporting care partners directly, which were not directions I thought I was heading in 5 or 10 years ago. And yet here I sit today with really developing an ecosystem around how do we provide mHealth supports for folks. So in all of this, I think one of the most important things is how are we engaging in partnerships with the people that we're trying to help, right? I think it's one thing to say there's this gap. It's another thing to say there's this gap and I know how I should fix it and you're going to like it when I give it to you, right? And so I think we really need to think about, as a community, how it is that we can ensure, even if we see a gap, one, that gap is important for our partners, for our care partners, for our persons living with dementia, for our healthcare system and team members, etc. And then if it is important, how do we engage with them around the solutions? Because what I might have this great idea, and I think the floor is littered with great ideas that either don't work or spin up in bad ways that end up leading to failure. I think if you look on the front page of the New York Times today, there is a story, not the paper version, no one gets the paper version anymore, but the website, there is a story about many startups currently failing after getting billions of dollars of infusion. And they never started with engaging their end users to figure out what they actually needed for some of them. And so I think we have this challenge that, move fast, break things, see what works, and then just pivot if it's not, rather than taking a more intentional approach that is more likely to create a final solution not a final solution, excuse me, a solution to address the problem that communities actually want, and that is implementable and sustainable, whether it's from a startup perspective, an academic perspective, a health system perspective, or otherwise. So broadly, there are many different co-design frameworks. This involves engaging with the communities that we're tending to serve, planning, exploring, developing, deciding, and then changing once we've developed our MVPs and our products, and continually going through this process as we move forward. And so, there are many different frameworks for this. If we look more recently, there's a systematic review in 2022 that looked at co-design approaches involving older adults. And I think there's some interesting things here. They found 9 different co-design approaches in 25 studies that they reviewed. So all different types of names: co-creation, co-design, human-centered computing, human-centered design, human factors, et cetera, et cetera. In the end, they all center around the same framework. There are some quibbles about how those are done. There's also not listed in here design thinking. So there are a number of different ways to go about doing this. But in the end, I think the important thing is that you do actually do this. And so one of the, if you look here, the overall mean was three and a half phases of this per study, going back around through that process. And if we look at similarly in health systems, there are a similar number of different ways of doing this. This was a systematic review of looking at how this is done in the health system landscape, and found that overall there are a lot of positive outcomes associated with co-design, but there can be some negative ones as well, especially if they're not managed well. If we overpromise and underdeliver, or take things but not talking to the right people, instead just talking to kind of the interested people, those can all lead to these challenges in implementation and outcomes. So I think there's a lot of good to it, but you have to, again, be intentional about how you're going to go through this co-design process. And especially as we're thinking about it in communities that are largely underserved, it is so important for us to be in those communities, to build trust, and to think through our approach to that co-design session, right? If you choose the loudest advocate as the person that's going to be your point for trying to implement something, you're often missing things, right? So it's really important to try and not just take the first person that's out there, the person that's loudest, but to try and really think through what are the characteristics of the different people that I'm trying to work with to develop something for these communities, different, and there are a multitude of communities, and who are the people within that I should be working with and thinking through. And it's not just the first 5 people that walk through your doorstep. I know in academics, we love, recruitment and enrollment numbers. That's not always the case with these approaches. You do need to make sure that you're getting the right people, and sometimes it takes some real legwork to get the hidden person. That's the one that you actually need to get to help the most and get their opinion. And a lot of it is trust building to get there. So, I'm going to shift gears into kind of the first example of this is a study that we've just started around machine learning and generative AI and early identification of individuals from underserved communities. So as we talked about, there's certainly poor diagnosis, a later diagnosis, or just complete lack thereof in many of our minoritized communities and those that are underserved. And there are a number of different ways to go about this, but you have to be really thoughtful about how you're using machine learning techniques, how you're using generative AI techniques, so that you're not introducing bias into the system, and so that you have great discrimination in a white population, and then mediocre to terrible in African American and Hispanic populations, for instance, and Asian American populations. And one of the challenges relates to how much access individuals have to care, how much they are using the healthcare system, because that's all data in, right? And so if you have less data from certain individuals, either because they only use the emergency department or they've never had a brain scan done or what have you, then you're likely to perpetuate those inequities. And so you have to be really thoughtful about that, whether it's generative AI, whether it's machine learning algorithms, about what data set you're working with, and understanding from the beginning what the biases that those create. So one example that we've done here, and this was led by Narjaz Rezavian. Dr. Rezavian is a machine learning specialist at NYU, an assistant professor in the Department of Population Health. And what she and this amazing team has done is use ChatGPT-4 in extracting data to understand if there are better ways to identify people for cognitive screening, or to augment machine learning with generative AI to make it more specific and precise. And so what we ended up doing, we had 135,000 clinical notes. So we pulled from clinical notes. One of the biggest challenges in Epic is that there are so many different ways to use Epic. And so often things do not get put into structured data. They just get written in random places. And so what we ended up doing was using sending these notes through generative AI, through ChatGPT-4, looking for cognitive scores or clinical dementia rating scores. We've also done this since then with other screening instruments with similar results. And what we found is we found lots of people who otherwise had no diagnosis code for dementia or cognitive impairment, had not had a workup for cognitive impairment, but had positive scores for having cognitive impairment. And it's important for our non-clinical friends that may be here that cognitive impairment alone is not really a diagnosis, and these are screening tools. So it's important to follow up by figuring out what the diagnosis is, and that takes some additional steps. But you can't do that if you're doing nothing after a screening test is done. And so sometimes these are done and they just sit there for whatever reason. So we found high rates of sensitivity and specificity. We had, the reason the name of lists here is so long of people that were involved in this is we went through and we chart reviewed a fairly decent subsample to ensure that if to look for the sensitivity and specificity of GPT versus hand searching. So we found high rates for MMSE. The CDR, which is a clinical dementia rating scale, which really is the clinician saying this is the level of dementia they have. We actually found very limited documentation, but the MMSE, which is one form of cognitive screening, as well as several others that we've done since then, showed high levels of presence, as well as high levels of sensitivity and specificity from GPT when we pulled it out. And so what we've ended up being able to do is starting a process for augmenting a machine learning algorithm that does have fairly good sensitivity and specificity in underserved populations and minoritized populations, and paired that with the Gen AI process for what's going to be our next phase here, which is helping to early identify and manage the cardiovascular disease effects that can lead to cognitive impairment. And so, if we were to go through this kind of like one normally might, we would say, okay, we've got this stuff. Let's just implement it as some form of clinical decision support tool in the EHR, and we'll check and see how it does. And if it doesn't work, we'll refine and iterate. The problem is in twofold here. The first one is when clinicians have something new that they don't like, they will find a way around it. And so if you do just implement something, it will end up creating workarounds that may actually cause harm. And so you have to be very careful when you're implementing things that you've taken into account people's workflows and thoughts and what's important to them, and implementing it in the right way, not just throwing another prompt out there. And on the flip side is, what do we do with this information? We have all of these challenges around trust, around social determinants of health that may affect ability to adhere to certain cardiovascular disease regimens. So how do people from these communities want to engage in cognitive screening and secondary prevention of cardiovascular disease issues like high blood pressure, high cholesterol, diabetes? And so this is where we are now, and we're using an intentional co-design process where we are going in, we've identified a gap, but we don't know how to address that gap fully. We know how technology can be used as a tool to help it, but if we set up the nudges for clinicians wrong, then we know the study will fail. If we set up the components around how we're actually going to talk to people about cognitive screening, how we're going to engage community health workers in working with the primary care provider and the older adult and their care partner in addressing issues around cognitive impairment and disease prevention. And how do we do that, right? We have some ideas. We have some ideas from the past literature, from other work that we've done. But if we don't go through and have that discussion first and ensure that our partners, both in terms of clinicians, in this case, primary care providers, as well as care partners and older adults from these communities, if they don't identify with the ways that we're thinking about, it's a lot of money and a lot of effort that's down the tubes for no discernible reason. And so we're starting this process now. We're going to be talking to a large number, I think about 35 older adults and their care partners, as well as and specifically from minoritized communities. So that's our inclusion plan, as well as primary care providers that take care of this population in addition. The goal then is to implement this in the real world and pilot test it to see how well it's engaged with. And we've even learned so far, before even getting down to the nitty-gritty interviews, that different parts of our system engage in these decision support prompts in different ways. And so they may have to be further tailored to address differences within our primary care clinics versus our federally qualified health centers, for instance. And so you don't learn that unless you're talking to people and you're understanding. And whether it's a more formal research process with qualitative interviews and focus groups as your co-design piece, or a more kind of loose and on the fly component with, if you're more on the industry side, of knowledge generation and understanding for your product, then you end up in the same place of no one's going to use it, and you fail. So, again, we are using this process before we go and implement something. So we know this is a problem from both the literature that's out there as well as past work we've done, and now we're engaging with these communities to help them. We're going to be planning then, and as part of that, exploring what the best options are, develop, go back and decide with them what the best approaches are to take. So we have 3 with our persons living with dementia and care partners. It's meant to be a 3 episode focus group so that we can engage, plan, and then in the end decide, plan and explore and then decide. So I'm going to stop there in terms of that study and move on to a different program that's used more on the M Health side. And you're going to see the same process take out, but in ways that we didn't think that were actually going to exist. And so, if we go back to the mission moment in the beginning, I was really trying to develop a program that was interdisciplinary, could help clinicians across teams to comprehensively, compassionately, and using evidence-based practices address behavioral symptoms, which are one of the biggest challenges for care partners, for the person living with dementia, and for clinicians, and provide the support necessary to help improve quality of life and understanding. And so I think one of the things to think about within all of this is, how do we approach this? And so we've taken a program that's revolved around a multi-component intervention, which is complex. It has engaged in development of training, of caregiver education materials, mentoring, treatment algorithms, and care plans that was all developed through working with the clinical teams that we were caring for and working with. And so, similar to what we just talked about, this whole program was set up initially first with home health agencies and then start to use with hospice around what are the needs and how do we implement in a way that is feasible for busy organizations to use. And one of the end goals around this is, we know that there are more supports for care partners and persons living with dementia that have means. And so how do we ensure in systems that are fully available, such as hospice, where there is fairly broad access in the United States, that they are providing effective care, that it takes culture into account, that it takes issues around mistrust and issues around accessibility and communication into account to address persons living with dementia. And so, when we developed this, we did use a co-design approach. I'm not going to focus on that today because it's less of a focus on the technology piece, but more on the intervention development piece itself. What I do want to focus is on where we end up going down unexpected roads. And so when we started to move this from a home health program to a hospice program, sorry, that was the wrong, something happened there. We ended up having to go back through another tailoring, another co-design process. And so we had a R61, R33, which was an exploratory, followed by a full-scale trial mechanism funded by NIA. And the idea here was to go through, test this with diverse populations, see how it would work, diversity in terms of both the clinicians as well as with the persons living with dementia and care partners. Again, engaging people early on to understand the differences in the needs in this population. And there were a lot of things that we found early on around how we talk to people, how we address needs, and trying to implement those things. And a few things that I wanted to touch on is how we engage staff. So we did pre-implementation huddles with both executive leaderships, data managers, and bedside staff to see where they felt their gaps were and their understanding were. We did some training and focused on the evaluations of the training to see where gaps were again. But we also focused on what were the things that, after we implemented this, needed to be altered further in order to be helpful within hospice and with working with diverse communities. And so where we ended up was a very similar co-design process, engaging people with diverse backgrounds, understanding their needs. In this case, it was on the clinical side. What we found was that the challenges around electronic health use were huge in these organizations and settings because they have very little ability to provide care, make changes to their EHRs. And so when we think about this from an EHR perspective, there are workarounds within the EHR. Those often fail, and they were unable to make significant changes in their EHR. And they asked if there were other ways that we could creatively solve that so that they could assess their patients. They also asked for things that around home health aides. And so, home health aides are generally part of the hospice interdisciplinary team, but are not. So they don't go to team meetings. They are usually individuals with lower education and socioeconomic status, are not included in discussions around what care needs to be provided. And yet, oftentimes, the home health aides are the ones who are most likely to be appreciated by the care partners, and also are the least likely to be asked, what help and supports do you need in the care that you provide? So we ended up receiving feedback that, our home health aides, which was not a big question mark in the home health agencies we're working with in hospice, this became one of the biggest pieces. We ended up developing videos with them that were co-designed to help address their needs, understanding what their needs were, tailoring their for both English and Spanish speaking populations, as many of the home health aides in some of the communities we were working with were Spanish speaking only and taking care of Spanish speaking only patients. And so we had to think through that component. And then the other thing that was a real surprise for us was in developing a mobile application. And there was consistent feedback that this was a important way to address some of the shortcomings of their electronic health record, something that could be flexible and usable within the communities that they were serving, rather than something that was stuck on a laptop that they had trouble keeping open during their visits, because then they felt it was taking away from their therapeutic interactions. And also could serve as a reinforcement point, because we could send out reminder nudges, essentially behavioral economic nudges around certain key elements of care. And so we ended up developing that whole slate. We had no intention of developing any sort of technology for this study. And we worked with our partners because this wasn't with NIA, because this was an exploratory award and fell within our aims of iterating, to develop this using some of our funds in that phase, as well as from an additional R01 where we changed some of the scope to work on this with a different program officer, and began developing this mobile application, testing it with diverse hospice clinicians to make sure it met their needs, testing the videos with the English and Spanish speaking patients and ideating on them. So going back through and having real humility that we didn't know what we didn't know. And that when someone tells you something, it may not be your perspective, and that's okay. And that's actually a good thing, because it's actually giving you the things that are more likely to be used, that are more likely to engage folks in the future. All of this is built on trust and on development of trust and relationship, right? So with all of these co-design processes, particularly when you're going into communities that are not your own, going with humility and trying to slowly build trust are really important in order to have a successful process. Otherwise, you end up with getting information, not receiving the right information or information at all. So, for me as an Arab American Jew, to go into a community that was largely Cuban individuals in South Florida, right? That, to develop trust in that setting, there are a couple of different ways to do that. And I think when we take these approaches, we really need to think about how we're going to build the trust to do all of this, that we're not going in and essentially what could be seen as colonizing, but instead going in with mutual respect and opportunity, and ensuring that people both feel heard, but feeling heard is only one piece of it. The other piece of it is that you're going back and showing them that what you did was actually based on the work that you provided. And if there are things that you can't do, for instance, that you're going back and talking about that and what are the other pieces. And that's why this is a circle. It's why co-design is a wheel. You need to continuously engage. And this also goes at the end when you have results, a final product, that you're going back and presenting that so that people feel that they were both a part of the process and that it wasn't just, oh, here you go, I'm going to do my thing and I'm going to leave. And so there are other ways that I think are really important as we go about in doing this to consider. One is that we don't just go in for the work that we're planning on doing, right? That there are other commitments that we make to the communities that we're going to be working with. So for instance, with one of these, we were, in addition to working on what the technology was going to look like, what videos were going to look like, we asked, what else would you like from us? What would you like to see? And the challenge with that type of question is sometimes you get a lot of responses and things that are not possible. And the other times people don't know what to ask for. And so you have to be prepared for both things that you can't do, as well as prompts and prompting for things that people never thought of as well. And so I think it's really important to consider all of this, how you're building trust, how you're maintaining longstanding relationships and not just colonizing, getting in, doing what you want to do and getting back out. And so we did this for this hospice process. The other thing that we learned in this is that, and this was something we knew already, but was really important, was that we knew that there was wide variation in technology adoption and technology ability within both our clinical teams as well as within the patients that they were serving. And so we had to go in with simplicity truly in mind when we did this. And while the designs that you're about to see are from 6 years ago, so they're since a little prettier today, but we went in with this function first approach and simplicity approach rather than creating the most beautiful thing that was going to might be great from a technology standpoint, but have no salience for the end users. So what we ended up with because of partner engagement was also included flexibility about how we collected data because of the limitations that the hospice EHRs had. And we also really did focus on Spanish language tools. So all of our education was not just translated into Spanish, but really culturally adapted for use in Spanish-speaking populations. We also made modifications because our team was heavy on nurses with some social worker engagement and physician engagement. And we found that even with social work engagement previously, that social workers felt that the work was not attuned enough to them. So we went back, or the communities they were serving. So we went back and we understood what it was from a social worker and a chaplain or spiritual care standpoint, what they wanted. And then we also took a precision health approach. So when we moved into behavioral economic nudges that were going to be coming as reminders for clinical team members, they were segmented out by population, by how people, whether people were taking the training or not, and providing nudges in that regard, by the discipline that they were. And so the nudges or clinical pearls that were important for them, giving a home health aide and a social worker and a nurse the same message doesn't really help to improve care. And so we really took a precision health approach using behavioral economic approaches in how to address all of those nudges. So, our nudges were all tailored. So these were sample emails or from the emails at least, and really focused on the things that were important to different segments. So this individual had completed their training, so we wanted to congratulate them on it, for instance. We always had a tool of the week that was aligned with where people were in their learning journey and were for their discipline. So just as examples of how you can get really targeted in a way that we often see for ad retargeting, or you click on something on a website and then you get an email, hey, this is still in your cart, for instance. Things that we haven't done a lot of in academic applications, and started trying to implement some of those pieces. Same thing for our application. It doesn't still look like this. You'll see in a minute, but it was really built around simplicity. There were four functionalities that were important, plus a favorite screen. That's all people wanted on their home screen. So we went back, we mocked up multiple designs, and then presented them back. And this is where we ended up, because it met, at the time, material design standards, which was, this was circa 2017, 2018, I think, actually, and then implemented it in a very clear fashion that was easy for non-technology centric individuals, people with less technology access to use. So we ended up having high utilization. This was just from one hospice. We're seeing thousands of records for caregiver strain, for behavioral symptoms. And it's also data that we've now been able to analyze and assess that we otherwise would not have had for our study. And so it led us in directions we never thought we would go, because we were being responsive. And then the last piece is it's pushed us even further, because as we were doing this, we started to receive requests to make a care partner companion for this, to help care partners help self-manage their work. And so this is a work in progress as well. And what we've ended up doing is a very similar approach, where we didn't start with a solution. We started with a request. We went to people, we asked what they wanted. We built and designed, we refined wireframes. We went back and got sign off and yes, this is what I was looking for. This is what I was thinking. And actually a lot of it ended up being, this was more than I thought I would get. And you do have to be careful about that, because that means maybe usability is not going to be as easy. We did this whole process with the care partner version focus, again, ensuring a diversity of sample, a diversity of education levels, so that we could move forward in thinking about what do different types of individuals need. I think if you go in and you start from a place of developing trust and understanding and what people want to see, and that is the starting point for where your work comes from, one, you're more likely to get to engage the people that you want, but two, you're more likely to design the thing that's going to be helpful. So, the things that have really, really helped in this was, in the beginning, working with diverse care partners, some more means, some from underserved communities, was to clearly identify the problem and identify the key features that people wanted. And then that was our starting point for developing wireframes that were then presented back later on. And we also identified and leveraged existing resources as we were going through this process that had already been tested and worked with in the communities that we were hoping to develop this for. And with, excuse me. And so, our solution went through different components of what people wanted to see. We used the design thinking approach within the user-centered design spectrum, and did a lot of ideation. The individuals that were engaged presented different viewpoints based on their lived experience of who they were and where they came from and what was important to them. And the interesting thing is they came up with a set of commonalities that across all of those things around assessing memory loss, around the prioritizing concerns, and creating a dashboard from which to build on. And this might sound simplistic. In some ways, it very much is. And that's what the end user wanted, right? So when I originally started thinking about some of these things, oh, do we want to get metrics around, pull in metrics from walking steps per day and build that into a precision health algorithm, et cetera, et cetera. And the folks said, in this group, we're like, why are we doing all this? We have three things that we really need. And so it wasn't about bells and whistles and all these other possibilities. And there were some interesting scientific reasons to go down certain routes, but there wasn't an end user reason in these populations. And there was some diversity of thought around this. Those people that look at their step counts tended to be and more interested in those types of components were from more well-off groups. And so we were thinking about, what is important to the groups that are most underserved, that are in our mission that we're trying to treat. And so just to kind of show where we ended up with, these were kind of the first sets of wireframes. They're in black and white. There's a lot of, we made a lot of iterations based on this when we showed this. And the reason to go simple first is because you're not putting all of your design and effort into a finished product. You're just trying to get a sense of, is this what people want to see in different ways? And there were a lot of things we changed based on this, and we iterated 3-4 times to get to the right place. And we did use design sprints, and we ended up going through this 3 times, refining with our group, and made 23 of the 28 requested changes. There were a few things that we couldn't make changes to, and we asked them if they were deal breakers, and the answer was no. Some of them related to compliance and privacy and protection. And some of the things that were really interesting was what terms people wanted to use. So I had always been taught that care partners and persons living with dementia wanted memory loss or memory changes to be used as a term. And the communities, our sample is mainly African American and Hispanic. They did not like that. They said changes in thinking. And we tested this in multiple different ways. And part of this goes back to positive aspects of caregiving and how do we frame things. And so it's a really interesting process that was because we were engaging our care partners that we changed design language as well. And we made sure that it didn't change the meaning of what we were trying to get at, but it did change how we presented that to people. That's just one example. And so just kind of in the end, to show you a finished product, so we have a little bit of time for questions. There we go. We ended up with presenting color schemes and designs, and wound up with this is our final design that we're currently moving forward with and testing. But it's really about the things that people wanted to see. So if we look on this left-hand side here around the care plan, they wanted that really to come out in a way that was highlighted around the care plan. And so that's why we ended up with the deep purple, because they wanted it to be on top and dark and very clear that this was an important element. So we went through all of these components to, with the individuals we were trying to serve to understand what it is that they wanted and how. So I think I'll stop there and, look forward to having a robust discussion or answer questions in the time we have left. So thank you.
Sorry, I'm trying to adjust my camera here. Let's see. Thank you so much for this great presentation and all this impressive work. I guess I would start with a question and also remind our attendees that you can post questions in the Q&A box. And maybe I'll start by asking you, you've clearly shown the value of participatory design and actually reflecting that in the design of systems rather than having the preconceived notions or assumptions that the researcher might bring to the system. Have you had any practical challenges as a researcher, whether it was through your IRB, where some of the iterative design may not have allowed you to know all the details up front, or practical challenges in terms of how to coordinate and reach out to these communities and engage them for the long term?
Yeah, so I think I'm very fortunate at NYU. So that, in terms of the IRB piece, our IRB both is very attuned to working across both different disciplines, different types of research, social and behavioral, pragmatic trials, all of this, in a way that I think a lot of other places aren't. So we can offer high stipends as well, right? So we do have to be careful about reporting so that we're not over $600 where you then have to report income. But we are very careful and thoughtful, and our IRB talks with us, right? So if they have questions, it's not just kind of a denied piece. We go back and forth until we hit a element that fit within the framework of the regulatory piece. I think a lot of IRBs unfortunately do get overly rigorous is the way that I'm going to put it for today, in terms of the restrictions that they'll put on. So for instance, I consider every care partner that I work with as a consultant, right? They are a consultant and providing valuable insight that I would not otherwise get. So if I want to pay them $150 for an hour of their time, they have an expertise as a care partner that I don't necessarily have, just as I might pay another academic consultant on a grant something else. And by using that framing, we've actually found that as long as you're not coercive in the way that this is done, we've actually found that works fairly well. And I know different places have different pieces. In terms of the long-term piece, NYU has a long history of working in the community and in the communities that we serve. And so this is part of our ethos in both the College of Nursing and the School of Medicine. And we work both individually in the communities. We also partner with people. So we partner with, for instance, Caring Kind, which is a Alzheimer's focused and dementia focused foundation that serves people in New York City, much like Alzheimer's Association chapters do elsewhere. And so by partnering with people, whether it's community centers, whether it's places like Caring Kind, it's not just about that individual event. It's about a longstanding and long-term relationship. And you also learn their needs as well. And I think the other piece that's important with that is if you are working with those types of groups, they are also compensating them and their staff for their time that they're putting into things as well. It's only one piece of things is compensation, but it's not the sole thing in building trust. But if we just go in and take without providing back both resources and other things that are important to the communities or the community partners we're working with, that's where we tend to see the most problems come up. George, you're on mute, I think.
So sorry, yes, I started reading a question. We are running out of time, but maybe for one last question, there is a question about how you see artificial intelligence playing a role in your work, and maybe also talk about future steps of integrating AI.
Yeah, so if we go back to kind of the first study I was talking about, I didn't get into the technical details. I am not a technical person. I do code, but machine learning is beyond my coding abilities. And so I think where our work comes in is how can you use these large data sets to be more precise, and thinking from nuts to bolts, from the beginning to the end. How do we use that to create precision approaches, but do it in a way that's not going to introduce bias? And so I think that that is really where where my team is using machine learning components, is in developing tailored algorithms that can then be used to predict functional decline in persons living with dementia, that can be used to predict what behavioral symptom is actually going to cause the most problems. We don't have really great clinical decision support or care partner focused decision support around these issues. So there are ways to use this. The key is finding the right data set that has enough people from enough diverse communities to provide a baseline for where you're not introducing bias and creating more yawning equity issues than we are, or disparities than already exist.
Well, Dr. Brody, thank you again so much for this great presentation. We will have the recording for folks to also watch later on our YouTube channel, and we'll be sharing the link with you. Our next webinar is, I believe, January 4th with Dr. Quintana from Harvard University. So I want to thank everybody who attended today. And again, thank you, Ab, so much for this great presentation.
Thanks for having me.